that benefit of a little bit of range. So with that, I'd like to invite Dr. LAJJA Shastri, who's a pillar at Raghudipai Hospital, and is very key to our counseling strategy and explaining to the patients how all these technologies will help them in day-to-day practice.
Thank you so much. Yes. So the question is it even possible to have a situation where we can consistently ensure that we do not end up having that nightmare of facing an unhappy multifocal IL patient? Yes, it is possible. With the past 2 decades of extensive research, we have managed to build up a fairly comprehensive list of factors that include patient factors and ocular factors, which, when evaluated in time and evaluated thoroughly, can actually help us prevent that unhappy situation. Since I cannot possibly talk about all of them, I'm going to share with you some actual patient experiences that will highlight the impact of those ocular factors on the ultimate outcome. The first patient I share with you was a kindergarten teacher who came to us complaining a lot about her foreign body sensation and watering and photophobia. So, a lot of ocular surface symptoms in addition to blurring of vision. The history is that she has been a myope all her life, and all her life she has only used contact lenses all day long. Until recently, when she was told by somebody that she has cataract in both her eyes, and she comes to us very eager to get cataract surgery done. She's using cataract as an opportunity to get rid of her glasses and contact lenses forever. So she's like, doctor, just go ahead. I want to get my cataract surgery done. When I start evaluating her, what I find is completely bizarre corneal aberration profile, which is not surprising. On tear film evaluation, I find that this surface is not even suitable for evaluation, let alone surgery. So I decide to postpone her surgery, and I'm going to put her on aggressive topical treatment for her ocular surface. Am I going crazy? This patient wants to get operated like yesterday, and I'm planning to postpone surgery. Is she going to run away and get operated elsewhere? Here is a very, very important lesson learned that I have in the past couple of decades, that if we sit a patient down and if we explain to them what we are doing and why we are doing it, nobody is going anywhere. They are going to come back to us and actually respect us more for giving their best interest a higher priority. So when I explained the situation, she agreed to wait. And what I'm showing you here is post treatment, before and after treatment. As you can see here, a completely changed aberration profile, a much better cornea now. On evaluation, when we find her to be suitable for a trifocal and when we give her that option, she jumps to it because she wants to get rid of glasses for distance and near both. So after both eyes trifocal lens implantation, extremely happy with her outcome, saying I've never seen so well without glasses ever before in my life. A very, very important lesson learned in this very happy story is that ocular surface disorders are becoming extremely common in our patient population. This one was because of extensive contact lens use, but I'm sure you would all agree, so many patients are coming up with varying degrees of MGD problems. The reason this is a big problem is because it can cause increased stray light. At any cost, we always want to avoid increased stray light for every patient, but especially those with a multifocal lens. Why? What is so wrong with increased stray light, and what is an increased stray light? To give you a brief idea, and this is something made by Dr. Samresh, so well demonstrated animation, whenever there is any irregularity on the surface of the eye, it could be epithelial degeneration or a poor ocular surface or just a small nebular corneal opacity, then whenever that irregularity overlying the pupillary area gets hit by the light rays, they get diffracted every which way, get scattered all across the retina, forming this thin veil of light, which is what we call increased stray light. Now, what this will do for the patient is that if this is what was seen by a person with a normal ocular surface, the same thing would appear like this for somebody with an increased stray light. Imagine this degree of glare and visual quality degradation. Any person with a multifocal lens with this kind of a surface will blame the multifocal lens and will make our life a nightmare. So we must pick this up in time. Also, like what Dr. Samresh mentioned earlier, it can cause an unreliable biometry. It will cause change in the IOL dioptric power calculation and will result in residual refractive error. So not only does an ocular surface disorder cause ocular surface symptoms, but it can also cause glare and can also result in a residual refractive error. All the things which are a perfect recipe for a patient becoming very unhappy with us. The second patient I share with you is a homemaker who comes to us unhappy following one eye cataract surgery elsewhere, saying that she's unable to read on her mobile. She's like, there's so much strain, I can't read very well. And although she herself does not drive, she feels that whenever she is sitting next to her husband and when they go out, she is very uncomfortable with the lights of the oncoming headlights of the cars. Now, when I look at her visual outcome in the operated eye, which is the right eye, and when I ask her if she's using any glasses, she tells me that why would I need to use glasses? I am told that I have a multifocal lens implanted. I will not need to use glasses either for distance or for near. Now, with this information, when I look at her refraction, what I find is that her vision improves to 6.6 with astigmatic correction and N6 with a low add power. On slit lamp evaluation, I don't see any diffractive rings because it is actually an EDOF lens. It is not a multifocal or a trifocal lens. Now, what this trifocal lens, EDOF lens is doing is that, as you can see here, in significant number of clock hours inferiorly, the anticapsule rhexis margin has slipped off the optic, fused with the PC, and this is causing the IOL to tilt a little. To demonstrate on aberrometry what this lens can do, this slight bit of tilt. This slight bit of tilt is causing, and these are the internal aberrations, presumably stemming from the EDOF lens, are actually causing so many higher order aberrations, also inducing astigmatism. But otherwise, this eye, operated elsewhere, is completely suitable for a trifocal lens. Now, with this in one eye, when we evaluate the second eye for which she has actually come to us, what we realize is that she's suitable for a trifocal toric lens. Since she is somebody who wants to be able to read well, and she has come to us so that, make sure that, the same problems don't happen in the second eye, we tell her that we can put a trifocal toric lens in the second eye, provided you do not compare your vision. We don't want you to keep comparing your right eye, left eye. We want you to use your binocular vision, and that whatever we are planning to do in the second eye should be able to address your problem. Following trifocal toric lens implantation, fortunately, an emmetropic outcome for which she is very happy about, but she's actually very happy about the binocular vision. Now she does not feel the necessity to reach out for glasses or not being able to read on her mobile. So very, very important lesson learned is that whenever a patient has been told that they receive a multifocal lens, if the visual outcome unaided is not all that good, it is going to be an unhappy patient. Let's not underestimate a homemaker. It could be a CEO, it could be a homemaker. Everyone has a right to expect the kind of outcome that we had promised. So making sure that there is no residual refractive error causing a poor unaided visual outcome is very important. Also, optimal surgical outcome is an absolute must. And when I say this, I don't just mean clear cornea day one. What I actually mean is that when we leave behind a lens, any lens, but definitely a trifocal lens, it needs to be covered 360 degrees by a anterior rhexis margin, symmetrically holding this lens in the bag such that the effective lens position for which we had used an IOL calculation formula and we had chosen a particular IOL dioptric power, that effective lens position is achieved and maintained. So we need to leave behind the lens in a correct manner for it to do a proper job of reaching the kind of refractive outcome we want. Also, trifocal lens and an EDOF or an extended range of vision lenses are not interchangeable. They each have a completely different visual performance spectrum. So we need to spend time with the patient, understand what is it that they want, what is the eye suitable for, and then match the lens with that particular eye. The final patient I would share with you was a little different compared to most others in the sense that he came to us all the way from another city to just get our opinion on the eye that he was very unhappy about. He was so unhappy with the multifocal lens he had received, and he was so convinced that there was something grossly wrong with his surgery or the lens that the operating surgeon himself suggested that, please go and get a second opinion. Now, since he unfortunately chose to come to us, the operating surgeon called us and told us, gave us a bit of an information why this patient is coming to us, and told us that, the surgery was fine, the lens is fine, there is no significant residual refractive error. I don't know why this patient is so bitter and unhappy with us. Now, when this patient walks into the consultation room, he looks like somebody's very benign grandfather. But the minute I ask him what his complaint is, in a fairly aggressive manner, in an increasingly louder decibel of voice, he describes in some great detail 10 different activities in his life where he finds his vision to be completely unacceptable. All his problems indicate that he is actually finding his vision to be hazy. And especially whenever there is low light, he's finding it very difficult to navigate. When we look at his visual performance, it's not all that bad. There's no residual refractive error as such. When I ask him if he's using any kind of topical treatment, he pulls out a note from the referring surgeon, and which tells me that this patient was found to have raised IOP during pre-op evaluation. And at that point in time, he was put on a PG analog for both his eyes, which please note, he's putting a PG analog in the operating eye, which he has been putting throughout surgery and post-operatively, and found to be well controlled with that drug. Also, the surgeon notes that although he could see the fundus, the details were not very clear because of the advanced nature of the cataract. Now, with all of this in the background, when I actually examine him on slit lamp, completely pristine corneas, quiet anterior segment, very well-centered trifocal lens, on aberrometry profile, there are absolutely no red flags, nothing going wrong with this eye. So what is the problem? Why is he so unhappy? The problem we find on dilated evaluation, significantly high cup disc ratio, 0.7, 0.8 CD ratio in both his eyes, with a dispeller which is significantly more in the operated eye compared to the other eye. So what we are looking at on PSOCT is a compromised optic nerve, which we could see on routine fundus evaluation also. What is happening here is that glaucomatous optic nerve damage done to the optic nerve of the eye, which is operated, which is causing poor contrast sensitivity, added to which there is a trifocal lens which has diffractive IOL optics, which also further lower the contrast sensitivity. Combined together, he's extremely unhappy with the quality of vision. So a very, very important thing, and I cannot emphasize enough how very important it is, that if at any given point in time preoperatively, if there is a reason to believe that this eye could have a suboptimal visual potential, either due to a diseased optic nerve or a diseased fovea or macula, it would be so much better to err on the side of being more cautious and not implant a multifocal lens of diffractive nature, even if the patient insists on it and even if he's very motivated, because it will compromise the quality of vision that they will be unhappy about more often than not. And one very, very important lesson, like what Dr. Samresh also mentioned, preoperative PSOCT evaluation, I cannot tell you how many times it has saved me from a very embarrassing result and an unhappy outcome. Getting it done for every patient, at least planning to undergo multifocal lens evaluation, would be a very important thing to do in order to ensure a happy outcome. I could go on, but finally I would just say that devil is actually in the details. So if we keep all these factors in mind, if we take the time to thoroughly evaluate the eye on slit lamp, examine the eye properly, making sure we spend time talking to the patient and understanding them, then it is not all that very difficult to make sure that every patient is actually very happy with their outcome. Thank you so much.